Hi, everybody. Thanks for attending. My name is Ryan Hansen. I'm with AbbVie U.S. Medical Affairs, and really a pleasure to have you all with us today. The topic that we'll be discussing today will be the clinical management of CLL on venetoclax specifically, and kind of how to initiate a patient, how to manage a patient through any adverse events they may have at the beginning of therapy. And it's a short presentation. It just should be 20 to 25 minutes in length, with a couple minutes at the end, perhaps, for a little question and answer. But it really gets to the heart of how do you manage through some of these things that happen with venetoclax. We're privileged to have a very talented practitioner with us today to give the presentation. We have Dr. Matthew Lay, who is an attending clinical pharmacist at Mass General in Boston. And with that, I will let Matt take it away. Matt, I think you might be muted.
Can you hear me now?
Yes. There's a slight echo, though.
Oh, okie dokie. Is that better? Sorry for the technical difficulties.
That sounds perfect.
Okay. So here are the disclosures for this program. And of course, today we'll be talking about the practical management of patients with CLL on venetoclax. And here is just some brief information from the prescribing information for venetoclax. And of course, we'll be talking about throughout this program the prophylactic strategies for TLS, as well as management of dose modifications with venetoclax as well, due to toxicity and also drug interactions. And of course, in terms of toxicities, some are highlighted here as well. And of course, some of the common adverse reactions are also listed on the slide as well. So just to give us an overview of this brief presentation, we're going to start with a pre-session survey. We're going to then talk about the practical management of a patient on venetoclax, and then just close off very briefly with a post-session survey, and then afterwards adjourn. And so just to start us off on our two pre-session survey questions, how comfortable are we in educating our patients with CLL initiating venetoclax? Are we 1, very comfortable, 2, comfortable, 3, somewhat comfortable, 4, not comfortable? Okie dokie. And so it looks like the majority of us are comfortable, and we have a little bit of spread in terms of very comfortable, somewhat comfortable, and not comfortable. And so at least we can hope to reaffirm and what we know, and also learn some new things as well during today to help us in the management of these patients. And so for the next question, I am confident in my ability, I am confident in my ability to manage patients with approved uses of venetoclax, including risk monitoring, providing prophylaxis, and educating on therapy initiation. True or false? Okay, so the majority of us do feel confident in our abilities to provide the required supportive care for venetoclax, and that's excellent. And then for the remainder, let's also dive right in. So venetoclax, given its widespread use in the treatment of CLL, offers an important opportunity and also a valuable opportunity for pharmacists to really add value to the treatment and the care provided to our patients. And the cornerstone of supportive care is, of course, going to be the prophylactic management of tumor lysis syndrome, or TLS, and especially related to prophylactic measures such as allopurinol and oral and IV hydration, and of course, also lab monitoring as well. And not to forget, but also in terms of something that's dear to our hearts as pharmacists, drug interactions. And given the older age of these patients, oftentimes the multiple comorbidities that these patients do have, that appropriate medrecs as well as drug interaction screens would be really important during treatment initiation, as well as the continuum of the treatment for these patients. And of course, if these patients do have toxicity, that we would be able to adjust and monitor appropriately the venetoclax dosing for these patients as well. And to start us off, in terms of the two different schema that are appropriate for venetoclax in the upfront setting and also in the relapse refractory setting, we see that in the first line setting per CLL14, that there's actually a lead-in in the obinutuzumab on cycle 1, day 1, 8, and 15, with venetoclax starting on day 22. And this is unique, partly because we're going to have to assess for TLS risk and implement appropriate strategies before the obinutuzumab. And we're going to have to reassess again prior to the venetoclax per venetoclax package insert. While in the relapse refractory setting, when venetoclax is used in combination with rituximab, of course, the venetoclax will initiate first, and after the week at the final dose level of 400 milligrams, rituximab will begin at that time. And so we see that, of course, the pre-venetoclax TLS assessment will have to occur. And the unique aspect of when it's used in the first line with obinutuzumab, that of course there will be a pre-obinutuzumab TLS assessment and prophylactic measures implemented at that time. And in relation to venetoclax, when we do assess patients for the risk for TLS, we want to categorize them as having low, medium, or high tumor burden. And of course, we'll be using this with objective information in relation to the largest lymph node in diameter based on CT, as well as someone's absolute lymphocyte count, or ALC. And given the combination of these, we'll stratify these patients into low, medium, or high. And of course, even if a patient is low tumor burden, and patients have a creatinine clearance of less than 80, or any just per your judgment or the medical team's judgment, where they do have comorbidities that otherwise would put them at a higher risk for complications, that we might want to be more aggressive in our monitoring or prophylactic measures if that is the case, and that's just something to consider. So we've categorized these patients into low, medium, and high tumor burden risk. What do we do now? Well, we want to implement appropriate prophylactic measures, and that's going to be allopurinol as our anti-hyperuricemic agent of choice. And of course, in my personal practice, if someone has high tumor burden, we might want to do 300 milligrams PO BID versus 300 milligrams PO daily. And in those patients who might not tolerate allopurinol, for example, if they develop a rash, then of course we can substitute that for buxostat. In terms of hydration, we see that's a combination of either oral or IV, IV plus oral if patients are high tumor burden. And of course, like I mentioned before, that this is going to be impacted by the comorbidities of the patient. Again, if a patient has renal dysfunction, pulmonary dysfunction, or cardiac dysfunction, let's say they can't tolerate the fluid load from the hydration, we might want to just monitor them more closely. And again, that would be a decision up to the medical team. And we talked about, we categorize these patients into low, medium, and high tumor burden risk. We then will implement appropriate prophylactic measures with allopurinol and oral IV hydration based on that risk. And of course, another cornerstone of TLS prophylactic management and monitoring is going to be monitoring of TLS labs and associated blood chemistries. And so once we separate these patients into those categories, for the low and medium tumor burden patients, they can be monitored as an outpatient. And of course, this is going to be associated with the timing of these labs. So of course, pre-treatment venetoclax labs are appropriate for all doses on the first day of each escalation. We would want to, for these low and medium tumor burden patients, grab TLS labs and associated blood chemistries 6 to 8 hours and then 24 hours after their venetoclax dose. So of course, these patients would just be coming into the clinic that day of their first day of dose escalation, and then come back the next day for their 24-hour lab check. And if everything's okay, then we can proceed for that week. However, for those patients who are high tumor burden, or those patients who have a medium tumor burden with a creatinine clearance of 80 or less, and also if those patients have associated comorbidities where the medical team might be want to be more aggressive in terms of the monitoring, then for the first 2 dose levels, 20 milligrams, 50 milligrams, this would warrant inpatient monitoring, just given the intensity of the monitoring schedule. Of course, the pre-dose, and then subsequently 4, 8, 12, and 24 hours thereafter. Subsequent dose levels from 100 to 400 milligrams for these high tumor burden patients would warrant outpatient monitoring with the additional nuance of that 6 to 8, and then subsequently 24 hours post-venetoclax dose monitoring. And when we take a look at what we just talked about, we talked a little bit about assessing someone's tumor burden risk. We talked about prophylactic strategies, and of course, the monitoring. And so this leads us into our first case with Mrs. A. So Mrs. A is a 76-year-old woman with a history of CLL with deletion 17p and T53 mutation, previously treated with FCR. She arrived at clinic with painful cervical lymphadenopathy. On physical exam, found to be 3 centimeters approximately. CBC reveals an ALC of 10, CMP in the black. And then after discussion with the medical team, and of course, with the patient who expressed her desires to not remain on therapy indefinitely, AKA time-limited therapy, the team decided to initiate treatment with venetoclax rituximab. So the 3 questions we have is, what is this patient's risk of TLS? And of course, from the CT, we see that the largest lymph node diameter is 3 centimeters, which is less than 5. Her ALC is 10, which is less than 25, and her CMP being in the black. And so given that those 2 pieces of information, we see that she would have low tumor burden. And of course, the appropriate prophylactic measures for that would be allopurinol, commonly allopurinol 300 milligrams per daily, and of course, hydration at 1.5 to 2 liters a day. So, and this leads us into our second case. So Mr. G, he's a 72-year-old male with stage 1 CLL, diagnosed 2 years prior. After 2 years of watchful waiting, he presents to fatigue, he presents to clinic complaining of recent severe fatigue and fevers. Relevant past medical history include hypertension, dyslipidemia, CBC revealing of ALC of 40, WBC of 48, hemoglobin 9.5, platelets 80. His CMP reveals a creatinine of 1.1. FISH revealing of a deletion 11q, and he is IGHV unmutated. Physical exam confirmed by CT reveals a 2x3 axillary lymph node. And of course, after discussion with the patient and the medical team, the treatment decision was to proceed with venetoclax obinutuzumab, time-limited therapy. So this leads us into a question. All the following counseling points on venetoclax treatment schedule and adverse effects are true, except 1, TLS prevention measures will be instituted, which will include daily fluid intake, 1.5 to 2 liters, as well as allopurinol daily. 2, he will start venetoclax dose ramp up over the next 4 weeks then return to clinic for obinutuzumab administration. 3, his initial venetoclax dose will be 20 milligrams daily for 7 days, with gradual increases per starter pack to a target dose of 400 milligrams daily. And we see that the answer accept would be accept 2. And this is because in the CLL14 schedule with obinutuzumab venetoclax, the obinutuzumab actually leads into the venetoclax ramp up. And so with this aspect of cytoreduction and a lead-in period, that of course, in terms of our schedule for Murano, where the rituximab begins after, that would be where that would apply. So Mr. G returns to clinic on day 22 of cycle 1. ALC is now down to 1.7. Lymph node size is 2/3. And of course, pre-dose labs, when we took a check, were within normal limits. And then he begins his first dose level of 20 milligrams at 7 a.m. this morning. And so when we're reviewing his treatment plan with the rest of the team. So in terms of the decision-making for us, which of the following actions should be implemented? Is it 1, TLS prevention measures will be instituted, which will include daily fluid intake, 1.5 to 2 liters, as well as allopurinol daily through ramp up. TLS labs order for 4, 8, 12, and 24 hours post-dose and scheduled to come back in clinic in 1 week. 3, TLS labs order for 6 to 8 and 24 hours post-dose and schedule to come back to clinic in 1 week. Or 4, 1, and 3. So we see it's 4. Given the decrease in his ALC from greater than 25 to 1.7, and that the largest lymph node diameter is 3 centimeters, for our patient, he'd be low tumor burden risk. And so for 2, this would only apply for patients who would otherwise be categorized as having high tumor burden. And so we just only would need, again, that oral hydration and allopurinol daily, as well as the post-venetoclax 6 to 8 and 24-hour monitoring. So that sort of wrapped up our little bit about TLS prophylactic measures and monitoring. And so another important aspect of supportive care and just management for these patients is considerations for dose modifications due to drug interactions. And it's of note and interesting that the package insert was recently updated, where prior to the update, the recommended dose modification for posaconazole with venetoclax would be to dose reduce the venetoclax by 75%. So if someone was at a target dose of 400, you would drop that down to 100. Given data submitted to the FDA related to the PK and safety of the combination of posaconazole and venetoclax in patients with AML, there was an update in this where now the recommended dose of venetoclax at the target dose level of 400 milligrams is now 70 milligrams. And of course, with other strong CYP3A4 inhibitors, we would still want to reduce the venetoclax dose down to 100 milligrams. And interestingly, still as it remains, that the combination of posaconazole and other strong CYP3A4 inhibitors during the initiation and ramp-up phases for venetoclax is contraindicated. And so from my practical experience in the clinic, and patients who do have fungal infections where we do want to cover for aspergillus or tree aspergillus, we'd otherwise rotate these patients a week prior, keeping in mind the 2 to 3 day washout to isavuconazole and keeping that on until a week after the final dose level, and then implementing that switch again. And for moderate CYP3A4 inhibitors and other PGP inhibitors, we would want to dose reduce venetoclax down to 50%. And of course, like I mentioned, with moderate CYP3A4 inhibitors or other PGP inhibitors, we can still use them concomitantly during initiation and ramp up, just given the feasibility with the dosing schedule and the doses of venetoclax available. And of course, we just want to also keep in mind that washout period as well. So here is just examples of strong, moderate CYP3A4 inhibitors, as well as inducers, and of course, PGP inhibitors. And most notably, in terms of the strong and moderate CYP3A4 inhibitors, diltiazem, voriconazole, fluconazole, isobuconazole, ciprofloxacin. In terms of PGP inhibitors that are notable, that are often used, amiodarone and carvedilol. And this leads us into our next case, Mrs. H. So Mrs. H is a 69-year-old woman with a history of hypertension, hypercholesterolemia, and diabetes mellitus. She was diagnosed with Rise stage 3 CLL in 2012 after presenting with fatigue and palpable cervical lymph nodes. She has CRS score of 7, CBC revealing a WBC of 20, hemoglobin of 9.8, ALC of 15, and platelets of 198. Flow cytometry revealing a clonal B cell population consistent with CLL immunophenotype. FISH revealing of trisomy 12, and she is IGHV unmutated. Relevant to our question, her current medications include carvedilol, metformin, torvastatin, and aspirin. So, given what we just discussed about required dose modifications for venetoclax, what modifications would we recommend to Mrs. H beginning first-line CLL treatment with venetoclax, given her medication list that we described? So is that 1, no modification; 2, reduce venetoclax by at least 50%; 3, reduce venetoclax by at least 75%; 4, change carvedilol to metoprolol; 5, change atorvastatin to lovastatin; 6, 2 or 4; 7, 3 or 4. And so when we sort of take a look through this, we see that can be either 2 or 4. We can either reduce the venetoclax dose by 50%, as carvedilol is a PGP inhibitor, or we could rotate that to a medication that does not interact and require modifications for venetoclax. So additionally, modifications may also be required in light of toxicities. And so if there's, in relation to TLS, if there's any changes in someone's TLS labs, blood chemistries, or otherwise symptoms that might be indicative of clinical TLS, then we would want to hold the next scheduled dose of venetoclax. And of course, given how the labs look and whether their abnormalities resolve, if they do resolve within 24 to 48 hours of the previous dose, we can just resume venetoclax at the same dose level. However, if the abnormalities don't resolve after 48 hours, then when we do restart after they do resolve, we would just want to reduce that to the next lowest dose level. And of course, the decision-making process with the medical team can occur later on whether or not to re-escalate the patient. When it comes to modifications for non-hematologic toxicities, grade 3 or 4, with the first occurrence after the toxicity has resolved to grade 1 or less, then venetoclax can be resumed without modification. However, if it's a second or subsequent occurrence for this non-hematologic grade 3 or 4 toxicity, then there will be a recommendation to restart after an interruption at a lower dose level. And although more common than less common in relation to hematologic toxicities, grade 3 neutropenia, grade 4 neutropenia is definitely more common than associated whether or not with an infection or grade 4. So in terms of whether it's a first occurrence, again, we would just want to hold if it's related to the venetoclax. And of course, administer any required supportive care. And so commonly in the clinic, we will do either short-acting or long-acting growth factor support as appropriate, depending on the degree and duration of neutropenia, as well as whether patients have infection or no infection present. And so in this setting, once toxicity resolves in terms of hematologic toxicities to grade 1 or less, we can just resume venetoclax at the same dose level if that was just a first occurrence. If in relation to grade 3 neutropenia with infection or fever, or grade 4, for the second and subsequent occurrences, we would interrupt and then restart at a lower dose level per the chart prior. And lastly, and also an update to the package insert in terms of dose modifications, In patients who do have hepatic dysfunction, specifically Child-Pugh class C, there is recommended dose reduction of the venetoclax dose by 50%. However, for those patients who have a Child-Pugh class A or B, there will be no recommended dose reductions. And so this just leads into our post-session survey. And of course, if there's any questions, please feel free to write them in the chat as well. So for our post-session survey questions, how comfortable are we in educating patients with CLL initiating venetoclax? Is that 1, very comfortable, 2, comfortable, 3, somewhat comfortable, 4, not comfortable? Okie dokie. So it looks like the majority of us are comfortable, very comfortable, and we still have some who are somewhat comfortable. And of course, there's amazing resources. I know that at NEHOPS and as well also throughout the conference that will offer more information on venetoclax and the management of these patients as well. And so for next question, I feel confident in my ability to manage patients with approved uses of venetoclax, including assessing risk, monitoring, providing prophylaxis, and educating on therapy initiation. True or false? Awesome. Looks like all of us feel confident in our ability to manage these patients by assessing risk, providing appropriate prophylaxis, educating them on therapy initiation. And so I found this presentation educational, true, or false. Thank you, everybody. Okie dokie. Thanks everybody for joining. Thank you for your time on this Friday afternoon. And thank you to Abby for sponsoring this program. And of course, if anybody has any questions, please feel free to leave them in the chat. Otherwise, I hope that everybody has a great afternoon and a great night.